So you have an isolated ward, you have an isolated HDU, but do you
Yeah.
have an isolated ICU, or you are managing the patient in the same ICU with other patients?
So most hospitals, what we are doing is that you are making a hot ward and cold ward, say COVID ward, non-COVID ward. And if you have a COVID ward, you are making, obviously you're not going to have lots of COVID patients on day one. You might have, for example, 6 bays in the ward where every bay takes 4 patients. And therefore, what can be done is you keep your first COVID patients in one bay and you get the other patients out of that bay and keep filling those bays as the patients come in. And those bays obviously will have to be totally isolated, separated out from the rest of the ward, and thereby you are preventing the chance of cross infection. Plus, any nurse which goes in to nurse those patients, they have to be in the PPE fully, same as doctors. And
And the
same with
PPE
HDU
which
as well. What we have done for HDU, we have planned for, and many hospitals are doing that. You have made one HDU hot and one HDU cold. So any non-COVID patients go into one HDU, which is not going to have any COVID patient, and the other HDU is COVID HDU, and therefore any COVID patients will go in that one. And ICU also, one should remember that ICUs will not have lots of COVID patients on day one. So ICUs should plan to segregate their areas, so where they can take their first COVID patient, second one, and so on. And as the as more patients come in, you fill up those areas sequentially rather than mixing them up, and thereby you reduce the chance. For example, in one bay there might be, I don't know, maybe 2 or 3 patients, and that bay is totally isolated from the rest of the ICU, and the nurse who is there for the whole of the shift, and they are in their PPE for the whole of the shift. They of course come out during their breaks. Say every 4 hours they're coming out for their breaks for half an hour or so, and then go back in. It's difficult. It's difficult for the nurses to be in the gear for the whole day. The masks are uncomfortable, and for many hours you have a mark on your face, etc. But that's the way to do it.
And what about the doctors? How long is their shift time at one stretch?
So doctors are doing at the moment 12-hour shifts most places, but that will be under constant review depending on the caseload. Generally speaking, a lot of hospitals are probably going to go up to 6 to 8 times of capacity. Lots of new ventilators are being bought and new arrangements are being made. So if this run goes on for a while, then obviously you have to give people shorter shifts, and that is under constant review. Intensive Care Society has come up with a psychological well-being guideline as well, because this is stressful time. And what very important issue is to give staff the confidence at the outset in the first 2 weeks, because that's when things go wrong. You don't know what the system is going to be. Therefore, one has to put things in place properly, communicate with every staff that this is our plan, this is how we are going to protect you, these are the store of masks, this many masks we have. Because if the management doesn't do that well, then the staff doesn't get the confidence, and they might lose their ability to function properly. They might be stressed, and that then propagates across the team.
And once
And
and once some of
in
the
in
healthcare
our
workers are also
yeah,
affected, which is happening in NHS itself, then the morale also goes down
absolutely,
exponential way. I'm
absolutely.
a
But
very
generally speaking, one thing I'll emphasize is, generally speaking, all healthcare professionals want to work in this situation, but they want to see that team leadership is with them. So we spent quite some time to talk to everyone and get them on board. So we have had the first year junior doctors, the intern level doctors here. They're coming up to me and saying that put me in any shift, I'll work. I don't really care whether you're paying me or not. I just want to be here. And that happened because we talked to them continuously and said that no matter what, we'll be all in this together. We are not going to throw you right at the front line. We will be there with you, and we'll make sure that you are safe. That's important.
okay. And I want to know a very interesting fact, that how you are making your roster. Is it normal roster, or you are mixing up some senior, junior, some ICU, some non-ICU guys put together. Because what we are apprehending also in India itself, that if there is a widespread amongst the healthcare workers, right, because it's not wise to expose all the senior and experienced staff together.
So this is an interesting question. A lot of hospitals have changed their roster completely. In response to this, I changed our junior roster last week, and this is starting as of today. Essentially, what we did is we totally forgot about what the roster was before. We made multiple teams of, say, in our case, we have made multiple teams of 4, and that 4 junior doctors are mixed with their skill set. Some are registrar grade, some are slightly junior, some are slightly more junior. And what we have said is, forget about which unit you belong to. You come and you start your shift in the beginning, and you decide, depending on the acuity and need of the day, where each one goes. And then what's also happening, so they are our core critical care doctors, but also don't forget that all the elective anesthesia lists are down. So there are lots of anesthetic juniors who are now available. So therefore, if you have, for example, in our case, you have got 4 core critical care doctors who would be then joined up by at least 3 anesthetic junior doctors, and that is then accompanied by 3 consultant grade doctors.
So
And what we are trying to do is to not to put, yeah,
now you can.
yeah, go on. Yeah, so what's also happening is we obviously you will have people who are maybe slightly elderly in the senior cohort, or you might have people with comorbidity. Someone is diabetic and so on. And what we have decided that they will do the back office job. There are lots of jobs which are not being done regularly, because people are busy with this issue. They can take over those colder work, that is, for example, writing letters and doing a bit of management administrative jobs, which doesn't need patient contact. So I think what's important is that you need to do a individual risk stratification as to, is my colleague on steroid, is my colleague hypertensive, is my colleague diabetic, and can we move them to an area where they don't need much
And
of patient contact.